Hello, my name is María Julia Cura. I am from Hospital Italiano de Buenos Aires, Argentina. I was an IPC Fellow in 2024, and I currently serve as an IPC Junior Councilor. For me, it's a real pleasure to speak today about paradoxical psoriasis. The classical definition of paradoxical reactions refers to immune-mediated diseases that are caused by the same drugs used to treat them. Historically, this phenomenon was first described with anti-TNF therapy. Overall, incidence varies across underlying diseases, and paradoxical psoriasis, as you can see here, is most frequently seen in inflammatory bowel disease. Now, an important point I would like to highlight is that recent reviews have expanded this concept. They now include eczematous reactions induced by psoriasis treatments and psoriasis-like eruptions caused by therapies for atopic dermatitis. However, if we apply a strict definition, paradoxical reactions refers to the induction of the same disease by the drug used to treat it. Since anti-IL-4 and anti-IL-13 drugs are not used to treat psoriasis, I personally believe these reactions should not be grouped within the same paradoxical category. In fact, from a biological perspective, when one immune pathway is blocked, the opposite pathway may become dominant due to immune imbalance. Two main clinical scenarios can be identified. First, new-onset psoriasis may develop in a patient treated for another disease, such as a patient who starts anti-TNF therapy for inflammatory bowel disease and then develops psoriasis. In the second scenario, patients with pre-existing psoriasis may experience a phenotype change. For example, these patients with palmoplantar pustular psoriasis develop a plaque psoriasis phenotype after starting adalimumab. The other possibility is clinical worsening, and this situation is particularly difficult to distinguish from treatment failure in the daily practice. Several genetic variants have been associated with an increased risk of paradoxical psoriasis, including polymorphism related to the IL-23 receptor, TNF, and other immune pathways. From a pathogenic point of view, in contrast to generalized pustular psoriasis and plaque psoriasis, type 1 interferon plays a central role in paradoxical cases. Just to highlight the main difference, in classical psoriasis, innate immunity is involved early, followed by a predominant involvement of adaptive immunity. In contrast, in paradoxical psoriasis, innate immunity predominates throughout all disease stages. Mechanistically, TNF inhibition removes a natural brake on interferon production, leading to increased interferon activity and sustained the skin inflammation. Moving on to predictors, studies in patients with inflammatory bowel disease treated with anti-TNF agents have identified several risk factors. Specifically, higher risk has been observed in women, smokers, younger patients at treatment initiation, patients with ileocolonic Crohn's disease, and those treated with adalimumab or certolizumab compared with infliximab. However, the autoimmune disease most frequently associated with paradoxical psoriasis varies across studies. In this particular analysis, rheumatoid arthritis was a condition in which anti-TNF agent is most frequently associated with paradoxical psoriasis. Similarly, there are differences between studies regarding which anti-TNF agent is most frequently involved. In one study, including patients with ankylosing spondylitis and rheumatoid arthritis, adalimumab was the most frequently implicated drug. In another study, including inflammatory bowel disease, uveitis, ankylosing spondylitis, and rheumatoid arthritis, infliximab was the most frequently reported agent. Overall, these differences mainly reflect prescribing patterns in each underlying disease. Regarding latency, the period between starting anti-TNF therapy and paradoxical psoriasis ranges from weeks to years, with a mean of about 11 months. Notably, in patients with ankylosing spondylitis, latency tends to be shorter, between 2 and 11 months. Regarding clinical phenotypes, some series describe palmoplantar pustular psoriasis as the most common presentation, while others identified plaque psoriasis. In addition, multiple phenotypes may coexist in the same patients in up to 15% of the cases. Another key point is scalp involvement, which may affect up to half of patients with paradoxical psoriasis. In fact, several reports have described associated alopecia, most commonly non-scarring alopecia, but cases of scarring alopecia have also been documented. Unlike classical psoriasis, skin biopsies from patients with paradoxical psoriasis may show three different histopathological presentations: a classical psoriasis pattern, eczematous stain changes, and lichenoid pattern. When looking at severity, predictors have also been studied. In this publication, severe cases were defined as pustular psoriasis, generalized psoriasis, and scalp involvement with associated alopecia. Here, adalimumab has been associated with greater severity compared with etanercept and with anti-TNF agents as a class. In contrast, older age at treatment initiation appears to be a protective factor. As therapy options expanded, paradoxical psoriasis has also been reported with anti-IL-17 agents. In this review of 28 patients receiving this drug class, secukinumab was the most frequent reported agent. More recently, a case associated with bimekizumab has also been published. Similarly, cases with different phenotypic involvement had been reported with other biologic classic, such as ustekinumab. Additionally, a case of generalized pustular psoriasis associated with risankizumab has been reported. JAK inhibitors are not exempt from this possibility, and although reported cases remain limited. This is an example of paradoxical psoriasis associated with baricitinib. Finally, treatment decisions depend on two main factors. First, whether the underlying disease is well controlled. And second, the severity of paradoxical psoriasis. If the underlying disease is controlled and psoriasis is mild, the biologic can be continued and topical therapies, conventional systemic treatments, and phototherapy can be added. However, in moderate to severe cases or when the underlying disease is refractory, switching to a different biologic class should be considered. Thank you very much for your attention.